Welcome back, everyone. Medical assessment. I'm doing the trauma assessment as a second video. That way, it's kind of two videos broken up to give you guys a little break. Just because if I were to incorporate both assessments into one video, it would be quite a long video, as I'm sure you can see why. So, just kind of continue on. Like I said, just refresh. My name is Douglas Keogh. I'm a full-time firefighter paramedic. I won't go through my full intro just because it was on the medical assessment part. I've been doing this for this is going in my 9th year as a paramedic, 10th year for sure as a firefighter, certified firefighter. So basically, like I said, I'm sharing this stuff with you because I have experience and field experience with doing this, and also I have teaching experience so that I kind of know what students kind of get worried about, what they get worked up about, and ways how you can avoid that and not get so fixated on one point necessarily as well. So again, that's the whole point of these assessments, and we're doing the MFR, EMR, National Registry Patient Assessment walkthrough for this. So like I said, right now we're doing the trauma. So I just copied and pasted my disclaimers again just because this is a new video, so I have to do this for each video I make, especially for the style of video that this is for. This material does not follow any specific book or published materials. This is meant to help create your own flow and help memorize the National Registry Patient Assessment Management for the medical and trauma psychomotor examination. I did not receive any payments or endorsements for this specific presentation. Like I said, I'm doing this on my own merit as well. I'm doing this to help out people, not because of I'm getting kickbacks at all. Anything. No, I've received enough input that help is needed or that I should do these, so I'm just kind of doing this on my own. Ultimately, follow your own local protocols and department standard operating procedures and guidelines, so your SOGs and SOPs. What I'm also doing here is the National Register of Emergency Medical Technicians, so NREMT, EMR, psychomotor examination sheets will be used during this presentation. So like I said, it's nothing new, nothing different. You can get these sheets online on the National Register website for free. It's there for you to access, especially if you're taking the EMR course. They're there for you so that you have a higher chance of passing on whatever level of EMS that you're doing. All levels are there from EMR to paramedic. So like I said, they're there for you so that you can pull them off and practice on your own. Hence the point of this video as well. And I assume no liability for how you use or apply this material. This presentation is made for helping those that are new to the EMS field with helping memorize and learn potentially different methods on how to assess patients for both medical and trauma-related emergencies per NREMT standards. Because like I said, I'm just following their standards. And here in the state of Michigan, you will get tested to the National Registry standards to get your Michigan license initially. So that's why we're following those guidelines. That's why this is kind of built off of that. Like I said, no published material. Like I said, just following the National Registry things that you can easily get on your own if you wanted to. So here, kind of like what I did with medical. So now with the trauma, this is a snapshot of the National Registry trauma assessment. So this is the sheet that they will be using for the actual patient assessment trauma. For your psychomotor examination, not evaluation, examination during your final practical day. The NREMT patient assessment skill sheets are updated and changed regularly, so always stay on top of it. This was the most current when I pulled this off a week and a half ago. They haven't updated these since 10 of 16, as you can see in the bottom right corner. That's National Registry that takes care of that. I would anticipate either an update coming out here soon. I don't know if they do it every 5 years or every so many years. So just keep your eyes peeled. I know when I started doing this 9 years ago, this sheet really hasn't changed a whole lot, even for the different levels of EMS providers. They just kind of changed the format and a couple steps here and there, but that's about it. So stay up to date with changes in national standard, because like I said, these sheets do follow the national standard of care as well, hence National Registry. Best way to really help get you through this is just memorize the skill sheet. I know it's a lot of points, but there is no easier way except to memorize what you need to know, repetition. And once you start repeating, going through these skill sheets, memorizing them, they actually get a lot better. They get a lot easier over time, especially when you practice with your fellow department members. You actually practice on each other. You hear input from them. It gets a lot easier, especially when you see other ways of doing it. Just make sure that you follow the sheet and that they're following the sheet so that they don't set you up for missing something. I'm a I'm a victim of it too, where over time you kind of get your own groove and it's easy to miss steps in the real world situation. So just make sure if you do that with your fellow department members that you have these sheets so that they have something to follow as well, that they can show you. And I'm sure they can agree, repetition is the best way for these sheets. So also be aware of the critical criteria on the bottom. That will be automatic failures if you do one of them, such as an example is you miss a step on the listed steps above. I have an arrow pointing to the critical criteria. I know for me personally, I did not memorize the critical criteria. I memorized each step, so all 40 points that you see here, because I viewed that that's what they want you to know. So it's a lot easier for me to memorize what they want me to know versus what they don't want me to know, because it's actually shown if you memorize things that you're not supposed to do or know, it's going to be in your mind a lot easier, so you're actually more prone to do it, is what studies are finding out. That's why a lot of wording is changing for teaching, where they say, do not spinal immobilize a patient on a spine board backwards. This is the correct way to immobilize a patient on a backboard. They don't word like that because you're going to remember immobilizing patient on a backboard, and you're not going to remember how. You're just going to say, well, we just need to do it. So, and that was a problem that they found out, and it was actually on the national level. It was a pretty neat article when I read it. I wish I had it so I could reference it a little bit better. But that's why I memorize the steps that they want you to know, because if you memorize the steps that they want you to know, you get all the points, you're done. If you memorize the critical criteria, you can see there's less critical criteria than there are steps. So again, memorize what you need to know. That's the best way for you to succeed, is memorizing what you need to know. I cannot emphasize that anymore. For this one, you will have 10 minutes for this whole sheet, which is still lots of time, especially for trauma assessment. The more you do this, especially for the trauma assessment, you'll breeze through this assessment station, because with traumas, you do move a little bit faster naturally because of the severity of them for the most part. So that's why, and you're going to see why, especially when we start breaking down this skill sheet, why you will be going through it faster, why I only give you 10 minutes versus 15 minutes for the medical. Medical, you're playing more detective work with asking questions. Trauma, you're doing more so the detective work with actually physically touching. So that's the big difference between the two. And a lot of these points are with actually touching and looking at the specific part to see what's going on, because they're assuming you have an unconscious patient or a patient that's not very accurate historian of telling you what's going on. And again, on the bottom here, I have the website NREMT.org. EMR certification is where you can find these skill sheets, and all of them that you'll be getting tested on, not just the patient assessments. All 5 or 6, I think it is, for the EMR level are there. So every first step, same exact slide as on the last video. Always take or verbalize appropriate PPE precautions. This is the first step for all skills, even for assessments. Do not forget to do this step before starting any, especially this station. This is an autofill. This is an autofill, I believe, for all of your skill stations for your National Registry Practical. So remember that. Always verbalize or physically take your appropriate PPE precautions. I know a lot of places just say just verbalize it because they can't afford giving you all the gloves and the actual gear that you need, so that they quote unquote verbalize it. So, but just remember, you have to say or do something for your PPE before you start any station, especially these. So now you're seeing size up. So again, this is identical slide to the last one for the medical, because it is the same 4 steps as the medical. So you're going to determine that the scene and situation is safe first. Ask the question out loud to the proctor and wait for the reply. You cannot do anything until the scene is safe. This is an autofail if missed as well. So you're going to ask, all right, I got my PPE on, or my BSI, or my standard precautions, however wording you were taught. I've seen all 3 of those. Whatever it is, say it, and then you ask them, is the scene safe? And the proctor will say yes or no, and then you will proceed from there. Once the scene is safe or deemed safe, especially by the proctor, you're going to determine the mechanism of injury and nature of illness. So you've been dispatched for a particular reason. Now, what are you seeing from what you were dispatched for? What is really happening now that you are there? Because as we know, dispatch information can be way different than what's physically happening there. Because again, God bless our are dispatchers, but they're not there to see. They're only as good as the information that they're getting from the person calling in, and usually the person calling in is very frantic to a certain degree or very inaccurate because they're all worked up from the emergency. And that's not dispatch's fault at all. So just know that and be ready that the scene may be different than what you are dispatched for. So that's why they say determine the mechanism of injury or nature of illness at this point, especially for trauma. Say you're dispatched for a car crash with one victim trapped. You get there, you see the car crash, but you hear no victim trapped. Okay, so now the victim got out somehow. How? Which is good, but you're determining what happened. Okay, so it was a rollover. What all happened here? Here, especially at the EMR, MFR level, you're going to request additional EMS assistance if necessary. Most likely you will be, just because here in the state of Michigan, EMR, MFRs don't transport by themselves. Especially if this is a patient that needs to be transported to the hospital, you're going to most likely get a minimum of a BLS unit with EMTs on it to the max of ALS unit with paramedics on it. Each scenario is different, obviously, with your area. I know here in Alpena County, paramedic ambulance is dispatched every time automatically with every MFR agency. So the ALS truck is on the way. But just know that in your area, or you have to say, I need additional resources or I need additional EMS assistance for this call because of this is a vehicle rollover. This patient will most likely need transport to the hospital, or this is a serious enough call where we need more resources. We need more EMS providers here. We need higher level of care for this patient for the care that they ultimately need in the end. But it's simple. It's just say, yes, I need additional resources or I need additional EMS personnel. That's it. Boom. And then you're going to consider stabilization of the spine, just like in the medical. So always consider this until proven otherwise, and you must verbalize your thoughts on it. So especially if it's a car crash, even if you have a patient that's ambulating around, you can say, okay, I'm going to consider stabilization of the spine. I'm seeing the mechanism of injury. Yes, I'm going to manually hold the C-spine in neutral inline position and apply a cervical collar at this time for this patient. Obviously, you're not at the patient yet, but you're considering it. So when you do make your patient contact, boom, you're doing it immediately. Because remember, these first 5 steps, you're not really having any patient contact yet. So the main takeaway for the size up is this can easily be completed in 1 minute or less. It goes much faster than you realize. So again, don't get too tied up on the questions. I was obviously just explaining each step more in detail so that you understand what they're saying and what they're getting at. That's why I was taking the time more, but as you can see, each step literally will take 3 to 5 seconds to complete, just because they're not very long. But the first 5 steps must be complete before you make your initial patient contact. They have to be done, and the proctor has to physically hear that you did them. Again, this is why I say just memorize what's on the sheet so that you know what you have to do for these patients right away. Alright, so now you get into your primary survey and resuscitation. So now this gets a little different for the trauma from the medical, and you'll see why here soon. But because order kind of changes a little bit for some of the steps. Not your ABCs though, but your order, such as so your first one is you determine your responsiveness level of consciousness, or your AVPU. So are they alert, verbal, painful stimuli, or are they unconscious? What state is the patient in upon first arrival? You have to determine that right away, especially for trauma, because time is of the essence here for these patients. That's the same on both assessments. Then you're going to determine the chief complaint and any apparent life threats immediately. So what happened to the patient? Is the immediate intervention needed for something right now? Especially from your mechanism of injury, if you haven't really determined the chief complaint because of what's going on, this is your time to either ask the patient, or you can physically see and say, especially for the trauma, what happened to this patient, such as if it was a vehicle rollover and you see bruises, scrapes, and cuts everywhere. They're walking around, but they have a lot of bruising and bleeding. Okay, the chief complaint is they have multiple trauma injuries at this point from what you can see and figure out with the patient because of the vehicle rollover. Until you start assessing more, it can change, but you're doing your initial chief complaint, and if you see any apparent life threats, intervene right away. Don't wait. because honestly, if you have a patient that's deteriorating immediately in front of you and you don't do anything, you don't have a patient anymore. Now you're not doing your job. That's why this step is there before you start your ABCs, because some apparent life threats are very crucial that they need intervention right now. So now you get into your airway, and I just have them bold because they're the ABCs. So you start with airway first. It's always ABCs in that order. So now here for the trauma, you have airway as its own category, and then you have breathing as its own category as well. But for airway, it consists of you open and assess the airway as appropriate, such as do they need their airway to be open? How is their airway? Is it a patent airway? I always do that. A patent airway or not? That's where you determine how their airway is right now. You open it as needed, and you insert an adjunct as indicated or as appropriate as well for that, especially if you have to open the airway. Usually they need an airway adjunct, whether it's an NPA, an OPA of some type, to keep that airway open. Because ultimately you're helping this patient survive. And now this leads immediately into the breathing, and that's why they have it in two separate categories, because usually you open up the airway first, insert an adjunct, now you can assess their breathing, such as yes or no. Are they breathing or are they not breathing after your first airway interventions? You're going to ensure that they have adequate ventilation. Can they breathe or do you need to breathe for them? Initiates appropriate oxygen therapy. Manages any injury which may compromise breathing ventilation. Is intervention needed right now to maintain life is what that's getting at. And this is your one chance to apply oxygen, and if you forget at this point, it is an auto failure, because the breathing section on your ABCs in the trauma section, the assess breathing, assures adequate ventilation, initiates appropriate oxygen therapy, and manages any injury that may compromise breathing and ventilation. Those are all 4 separate steps in the breathing. Compared to the medical, that wasn't there. This is now because, again, if this patient is not breathing, and if you're not doing anything for this patient for breathing, to help them breathe, this patient will die immediately. And you're not there to let patients die, you're there to help patients survive. That's why you are intervening immediately with these interventions in this order. Because once you secure the airway, now you can do other things as appropriate or if needed. So again, but this is your one chance to apply oxygen. If you forget, it is an auto fail. Not like the medical, where if you forget at first in the ABCs, you kind of have a second chance because you may have time on your hand. If you have time with your medical assessment, that's fine. But your trauma, you don't hear necessarily. They take that time factor away, especially with the medical, because you can dig deep into it by asking questions. At first, you may not seem like that they need oxygen, then you can apply it later. Here with trauma, these patients need oxygen right away because you're treating for shock, you're treating for they're not able to transport oxygenated blood very well because they're losing blood, so they need oxygen intervention immediately. That's why this is there. And then you go into circulation, so you're going to check your pulses, then you're going to assess your skin, such as the temperature, color, and condition. So your temperature, obviously warm, cold, normal, hot. The color, is it pink? Is it pale? Is it cyanotic there? Early morning, sorry, I'm still drinking my coffee. Cyanotic, or is it any other color? Is it ashen? Is it red? And the condition of it, is it intact? Is it so beat up, full of bruises? Is there lacerations everywhere? Is there a sloughing of the skin? What does the skin look like? Is it diaphoretic? Is it hot to the touch? Like drier than normal feeling, almost like a desert. Then you're going to assess for and control any major bleeding, such as any major bleeding you can see at this point, even if it's through clothing, because it's going to soak through at this point. So you're going to deal with that major bleeding right now, because again, once you deal with your airway and breathing, great, they're going to stay alive now, but they can still bleed out. So that's why with these, you kind of fly through them a little faster, and it's easy to miss these steps still. So that's why it's very important to memorize what each step is in each bullet point of the ABCs. You're going to initiate shock management, so proper patient position, conserve body heat. And what they mean by patient position is laying supine. They're going away from the Trendelenburg position, but some systems still use it or deem that it is appropriate. I know here in Alpena County, we still do it here just because of practice. It has shown to help Granted, there are studies out there that are inconclusive for it, but again, that's a system by system thing. So I just know that's what they mean by proper patient position. Usually, what natural registry means is, are they supine laying flat, and that's what they want, is laying flat, supine, and you're keeping them warm, and they have oxygen on, especially for shock management. Because if you lose blood, you're not able to carry oxygenated blood throughout the body. They're not perfusing, and they need that oxygen now as much as possible so that they can capitalize on as much oxygen as possible. And for circulation, each of these 4 white points, the check pulse, assess skin, assess and controls major bleeding, initiates shock management. They're all 4 separate points individually in the circulation. So it's 4 points in that one alone. And then you're going to identify patient priority and make treatment transport decision. And they say GCS here, especially if you like the GCS. I'm not a fan of the GCS scale personally. I'll explain it here in a little bit. But just know that if you do like the GCS scale, or if you are asked to do GCS scale, it's at this point that they're going to say, okay, what would you rate this patient on a GCS scale? I have not seen any testing facility fail you if you guessed wrong, as long as you're able to justify your point value with your findings. That's all they care about, to show that you know about the GCS. But that's, again, and that's a test site by test site thing, though. Out of my years of doing this, I've never seen someone ask for the GCS scale, but this is new for me to see that. So just know that it could be there. So just make sure you know your GCS scale for this, because the GCS scale is good for trauma. That's why, not so much medical. That's why it's in this trauma assessment and not the medical one. And it's an autofail if you do not identify the urgency and priority that the patient needs to be transported immediately versus staying on scene, and you must verbalize your rationale. This is number 8 on the sheet of the autofails. That's why I have that there, because this is a super important step, and it's very easily missed because it's a very thin spot on the patient assessment sheet overall. Very narrow point. So that's why I have this, and I can't overemphasize it, and I'll read my bold section here. Because if you do not treat immediate any life threats found in the ABC section, or move on from this section before intervention and treatments, it is an autofail. And those are number 7 and number 9 on the sheet as well. So number 7, 8, and 9 are autofails. If you move on from your ABC section, your primary survey section, without doing them, you autofail. But granted, you'll still continue with your assessment, but you're going to fail ultimately. The practice won't stop you there, but they're going to let you keep going. But just know that, get ready to take it again, because you just failed your entire trauma assessment. So, and it's bold because this is very important. This is a very easily missed step. And I say that because, again, out of my years of helping teach this stuff, this is one that a lot of students miss, or misprioritize, or they just breeze through it and just think it's not as important, when really this is important. Because like I said at the beginning, EMR and MFRs can't transport themselves. Unless they get an EMT or paramedic there, then they can help out with the transport. But you need to prioritize appropriately, especially because you're most likely going to be staying on scene. But how you're going to prioritize this patient comes down to triaging if you have to, or how aggressive are you with your interventions and treatments for these patients. Show the urgency, especially for trauma, because trauma has a higher mortality rate than a lot of other things than compared to medical, because of time-sensitive injuries. That's a big crucial thing. So I'll get in my GCS little soapbox here real quick, because just so I can explain my rationale so that you understand why I don't really care for the GCS scale. Because the GCS scale, so as you know, it's a point system from 3 to 15. The normal GCS scale, there's a revised trauma GCS scale, blah, blah, blah. Don't worry about that, because that's not what this is asking for. This is asking for the actual normal GCS scale. So you have 3 to 15. Your 3 points is unconscious or unresponsive or no response at all to all 3 categories, which is your motor, speech, and eye movement are your 3 main categories. 4, 5, and 6 for your point values, which makes 15, which is your highest, which is your patients that are awake, oriented, or able to follow commands, purposeful eye movement, all that fun stuff. Now, when you start going down in points, such as 14, 13, 12, 11, 10, 9, when you start going down, the less number you have, the more chances you get of making up that number. So your probability of making up a number 10 is much greater than making up a 14 or 13. And so when you radio it, so when a number 10 gets radioed into the hospital or to me, how did you get that 10? What categories did they fault on, or did they lack in, and what did they do well in? I don't know until you physically tell me. So when they say, well, just give me my GCS number, it tells you nothing. You don't know how they got that number, because there's many different ways of getting a number 10. There's even more ways of getting an 8. There's like 3 or 4 ways to get a 13 and a 14. So that's why I don't care for the GCS scale, because it doesn't paint the picture to you, especially when you just say the number. Now, if you say they are a 14 because they have purposeful eye movement, so that's a 4, but they're confused, that's a 4, and they're able to follow commands, that's a 6. So now you have 14 that way. Okay, great. You just told me why they're a 14. So they're confused, we don't know why, but they're still fairly with it. So my priority is still lower in this patient because they're still able to have purposeful eye movement, still able to follow commands. They're just confused overall. Why are they confused? That tells me something more than just saying, well, they're 14. Well, which category did they lose a point in? Because you have 3 different ways to make a 14. And then it goes up exponentially from there for 13, 12, 11. So that's why I say I don't care for the GCS scale that much, especially for trauma and medical. I don't care for it. I have learned that it is not an accurate scale overall unless you physically tell the person why they got that number, which most people don't. And most doctors don't care. They just want the number, which I disagree with. So that's my little soapbox on the GCS scale, but just know that it is a tool out there that you do have to know, and it is there for your assessment tools as well. It helps you rate how they're doing overall. So that's the point of it. So now here's where the order kind of changes a little bit from the medical assessment for the trauma. So now here in your history taking section, after your, I think they have a primary survey, so I just forgot what it was. I like saying initial assessment or primary assessment. That's because when I went through it, that's what they called it. So now you have your history taking. So now you take your vital signs. So here you get your blood pressure, your pulse, your respiratory rate, and quality at a minimum, such as your proctor wants to hear when you say, okay, I'm going to get my vital signs now on this patient. They're going to hear these are the main 3 to get. There are more that you can do, such as your SpO2 and blood sugar, depending on the situation, if it's deemed. And they should have those values for you, but they at least want to hear you say, well, what's my blood pressure, what's my pulse, what's my respiratory rate, and quality, or evaluate it on if you have a person to demonstrate practicing on. So those are the main 3 that you have to get, and you do it much earlier, as you can see here, because your vital signs are an indicator here, obviously more so in trauma than medical. Now here you're going to attempt to obtain a sample history if you can, and only if you're able to, depending on your patient condition. Obviously your sample history requires your patient to talk. If they're unconscious or greatly altered, you can't get this sample history. Your proctor will understand it, especially if you say, okay, now I'm going to get my sample history after getting my vital signs, but my patient is unconscious or has an altered level of conscious where they're incomprehensible. I am unable to obtain my sample history. Boom. Good job. You're done with that step now because you explained why you can't get your sample history. You told the proctor, hey, I tried, I can't, and here's why. So I hope you're starting to pick up now on these stations where as long as you explain your rationale for each station, you're going to get the point. So that's the whole point of this assessment evaluation, is to see that you know what you're doing. That's the whole point of it. And then just real quick, so your signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and events leading up to. That's what SAMPLE stands for, again, because it's an acronym. Very easy to remember. And this must be completed faster than normal. Remember, this is trauma. Time management is crucial. You still only have 10 minutes to do the entire trauma assessment. A lot of people get hung up, especially here in the history taking, trying to get the sample history, because what they'll do is they'll take their time to try to get the patient aroused enough to talk to them, and now they're losing 2, 3, even 4 minutes here trying to get a sample history when really they should have just moved on and just explained why they moved on. So just be very careful here. It's kind of easy to fall in the rabbit hole here of getting stuck on the sample history because you're trying to get it because you say, well, it's on the sheet. But that's why they say on the sheet, attempt to obtain a sample history. You're going to try. If you can't, you can't. No big deal. Move on with your trauma assessment. So now you get into your secondary assessment. So now this is where you kind of really pick up speed, headway, if you're a little bit behind the 8 ball. Because this is where things kind of start rolling a little bit faster, a little bit easier for you. Because from here on out for your secondary assessment, this is where you touch everything and you say everything you're touching and you inspect everything, so you verbalize everything. So whatever category we go through here now, you're gonna inspect and palpate, as how they have it worded on your eval sheet. So basically for your head, you're gonna inspect and palpate the scalp and ears. You're gonna inspect the mouth, nose, and assess facial area. So like their face, you're gonna check. And also you're gonna assess their eyes. Obviously you're not gonna touch their eyes. And you're also not gonna really stick your fingers in their mouth. You're gonna look in their mouth, look in their nose, and you're gonna you're gonna palpate the facial area. So pretty much, if you are fire base, or you've got your fire 1 and 2, if you remember your SCBA inspection station, if you touch everything, you say what you touch, you're gonna pass. This is where that same rule applies. Touch everything on the head, everything on the head. If it's an orifice, you're gonna inspect it. If it's bones and skin, you're gonna palpate. If it's a hole somewhere, like a mouth and a nose, you're going to inspect it as well. Eyes, make sure you assess the eyes. That is a very important finding for the head assessment. So again, we're going to proceed to the neck now. So you're going to see how it's going to continue on. So you're going to check position of trachea. So you're going to assess it or inspect it. Make sure it's midline and that there's no right or left deviation. There's no punctured or collapsed. Check jugular veins. Are they distended or flattened? Obviously, you can assess these. You can't really palpate these, but you're going to see them if they are. You're going to palpate your cervical spine if you haven't already here. So here, again, here's where you start palpating again. So you can palpate the front of the neck where you can touch the trachea, check the position of it. You're going to wrap around and palpate the back of their neck. You're going to palpate all the muscles. You're going to palpate the cervical spine of the neck. So not much there for the neck, but again, you're going to palpate the entire neck. If you want to, you can check for a carotid pulse. Obviously, if they're breathing, if you have a viable patient, they most likely will, but it's always a good idea to check for a carotid pulse, because if you say, I'm checking for a carotid pulse, and your practice says, well, you have a weak carotid pulse, that kind of tells you something where, okay, carotid pulse is weak, this is bad news. Something major is happening with this patient, something needs to happen now. There's a reason why they have a weak carotid pulse. We got to get moving. There's a problem that we have not found or fixed yet that needs to be fixed. So you're going to continue on your assessment. You're going to go to the chest. You're going to inspect the chest, palpate the chest, and auscultate the chest. Again, so you're going to look at it, feel the chest, and listen to the chest. The reason why is because you're going to listen to your lung sounds. Remember how you listen to your lung sounds? You start either on your right or left, and you go side to side with your 4 points. So if you start in your left upper, you're going to go to your right upper next. Then you do your left lower, then you go to your right lower. You're comparing sides, not necessarily sides such as right and left, not up and down. Because you want to make sure that both of your lungs are functioning properly or one is not collapsed. That's the whole point why you auscultate like that. And then you're going to inspect, is there any bruising? Do you see any deformities? Palpate, do you feel any crepitus, any broken bones? Does the patient react to any place you palpate on the chest? Very crucial structure is the chest. It's where your heart, it's where your lungs are, it's where your vital organs are for survival. So that's why you inspect, palpate, and listen. Also, you can listen to your heart tones. What does the heart sound like? Is it muffled, or is it normal sounding, or is it absent sounding? Very important findings, that's why. Then you move on to your abdomen and your pelvic region. Again, you're going to inspect and palpate the abdomen, just like with the chest. Make sure you have a systematic approach when you palpate and inspect the abdomen, such as start either your right side, whether it's upper or lower, or if it's the left side, you start. Make sure you kind of go around. You feel the entire abdomen. Is there any masses? Is there any bruising? Is there any distension? Is there any lacerations? Is there any eviscerations there? Very important findings because this is where you have a lot of major organs as well, where they're not going to kill you right away necessarily, but you have a lot of major organs that the patient will die from relatively fast. Not compared to the heart and lungs, but these patients will deteriorate rapidly if there's a major injury to this area if you don't find it. Especially if you have masses where they're bleeding underneath, you feel that, or if there's an evisceration where they have organs protruding from a penetration injury. So that's why it's important to inspect and palpate. Then you're going to assess the pelvic area. You're going to look at it, obviously. Is there any deformities? And you're going to palpate. Do you feel any movement at all? Any broken bones? And here, make sure you have a systematic approach for the pelvic region for assessing it, such as you're going to kind of test or assess the pelvic girdle, such as you're going to push in. And if it causes pain or hearing a cracking, then you're going to push down. Because if you push in, and if they have pain or cracking, they're going to have an injury of some type to the front and back side of the pelvic region. If they push down, then they have injuries to the side of the pelvic region. So that's why it kind of pinpoints where the cracks are at. Especially for the pelvic region, usually one side, it's not one side or portion is affected. Remember, it's a ring, so it's going to be equally affected. Whether it's the front, the back will be affected. If it's the side, the other side is going to be affected. That's why it's important to thoroughly assess the pelvic region. And also, you're going to verbalize assessment of genitalia, the perineum, as needed. Here, your proctor is obviously not going to say, okay, drop their trousers and look at them. You're going to say, no, I'm verbally assessing their genitalia. Is everything fine there? And your proctor will be like, yes or no. But they're usually going to be very good with you, where they're going to be like, yeah, that's fine. Okay, you got the point. Boom. Move on. Only because you're going to be practicing on people here for the most part, and obviously you're not going to drop your dummy's trowel for a normal person in the middle of a classroom. That's why. So just make sure that you verbalize that you assessed it. Then here, it doesn't matter what order, whether you do upper or lower extremities first. Really, the important thing is make sure you have a systematic approach. If you like doing upper first, stick with doing upper first after you do your abdomen and pelvic region. If you like doing your lower extremities first after you're doing your pelvic region and abdomen, then do your lower. Just make sure whatever you decide, you stick with it so that it is concrete in your mind and that you are formulating your systematic approach for your assessment on these patients. Oops, sorry about that. Dropped my phone a little bit. Just checking the time. So your lower, pretty much so for your lower and upper extremities, I'm just going to go in the order that the sheet gave it. So they have lower first. Obviously, you're going to inspect, palpate each extremity individually first. Make sure that not one extremity is injured compared to the other, because if you do both extremities at first, whether it's upper or lower, such as you go down both legs at the same time and they go, ow, well, was it the right or left leg, right or left arm that hurt? That's why I say that. So make sure you do one leg at a time for inspecting and palpating. Then when you assess your motor, sensory, and distal circulatory functions in each extremity, make sure that they have their sensory in each extremity individually first, but also you can check pulses at the same time, and you can do the motor at the same time, such as so for like the lower extremities, you can say, okay, push on my hands, pull up on my hands with both their feet at the same time, because what you're doing is when you compare that, you can see if one extremity is affected more than the other. That's why that's important to do that together at the same time, especially for pulses, because if, let's say, they have a right leg or a right knee injury, but they have good distal pulses, but all of a sudden now they can't move their right foot compared to the left, you can gauge how severe, such as if there's no movement, a little bit of movement at all, or they can move it just fine. It gauges what so you can see what's normal for the patient to, okay, this is not normal for the patient, and you have a good comparison as to what degree of severity is not normal for the patient. The same thing applies to really the upper extremities from the lower extremities. So you inspect, palpate each extremity individually first. You want to assess your motor, sensory, and distal circulation in each extremity individually. So basically, to kind of cover your distal circulation, so in your lower extremity, so it's your feet, you have your dorsal pedal pulses, which is on top of your foot. That's what they mean by checking your distal circulation in each extremity. Obviously, if they don't have a foot, remember your pressure points for your extremities. Take whichever next pressure point you have, especially if they're an amputee of some type, such as from a pre-existing condition, or if they have an amputation in general from the trauma injury. Obviously, if they don't have a foot from an amputation, whatever type, don't say, well, they don't have distal pulses. That's not true. They can still have distal pulses. You just got to find at what point do they have them versus not having them. So then in your upper extremities, it's your wrists. Obviously, that's where you start. You have your radial, your ulnar arteries. Your radial is going to be your primary one to check. If you struggle with that, try your ulnar. I just say that because a lot of people forget about the ulnar pulse. But it is there. It's usually weaker just because it's a little bit in there more buried compared to the radial. That's why the radial is the big one. And remember, we don't check pulses with our thumbs because our thumbs have our own pulse points in them, so it's easy to get them confused with the patient versus our pulse. So that's why when we check pulses, we use our index, middle, ring finger, and pinkies. We use those four instead of our thumb. If you have to, use all four push down so you can figure out if you. I do that at times, especially in traumas. If I struggle finding the pulse with my index and ring finger together, just because you only cover so much area. If you line up all four fingers at once and you push in the general area, you have a higher chance of finding that pulse that much faster and that much easier. That's just a method that I learned over the years of doing it. It works very well, especially if they have like watches and stuff like that on, or on their foot if they have pre-existing medical conditions that give them weaker pulses in their feet, or if they have swelling from water retention. Get a bigger surface area for your hand to cover so that it's a lot easier to find it that much faster versus you just kind of fishing around with two fingers on whatever extremity. That's just a food for thought trick or tip that I'm sharing with you guys, just because, like I said, that was just an experience thing. That's all. Whether you use it or not, again, up to you. Just like I said, it works for me, and I like it because it's faster. So when doing motor assessments, have them do both right and left arms at the same time to compare to find potential deficits. Again, I already went over that. Then you move on to the posterior thorax, lumbar, and buttocks. It's funny, buttocks, but they only have one, but that's just how it's spelled out. So you're going to inspect and palpate the posterior thorax, lumbar, and buttocks area. So basically, for this, have a systematic approach for this because the patient is usually on their side and is commonly uncomfortable for the patient. So even if you tell the patient, hey, we're going to roll you on your back to check your back real quick, don't have them on their back for a long period of time. Make sure when you do this, do it fast. Because the second you roll them, the patient will be like, yeah, that's fine if you roll me. You roll them. Now you're shuffling all their weight onto a whatever side, whether it's the right or left side. Now you're focusing all of that weight there, and if they have any internal injuries in their chest or abdomen, you could potentially cause more pain for the patient because all that is shuffling inside them now. So make sure when you do this, you do it once and you cover all of your bases from the get-go. So like I said, have a systematic approach for this. When you do this, so make sure you inspect and you palpate at the same time along their spine, the back of their chest, the back of their, I'll just say their flanks where their kidneys are. I was going to say back of their abdomen, but that doesn't make any sense. Their flanks of their back, and into their butt region. Do it all rapidly. Have lots of eyes if possible for this, because the more eyes you have on this, the faster you can move for this, and the less likely chance you're going to miss something too, especially this portion, because this is an easily missed portion of secondary assessment because it is the patient's backside. A lot of students will miss this because they just forget to roll them. If they don't see it, it's out of sight, out of mind. That's why. So that's why this is easily missed, where just you get the tunnel vision where you see them on their back, so you get everything that you can see. So just know you have to do this. And a real life application here, especially if you're going to use a backboard or a sheet to extricate them or carry them somewhere, make sure you have your tools ready to go when you roll them on their back at first, because when they're rolling from their back, because once you roll them onto the side and you do your assessment, right now is a good time to place whatever tool that you're going to use to carry or extricate the patient, because they're already there. You don't want to roll them back on their back a second time when you're assessing these patients. Do it once. Have everything ready to go, especially for this. And especially in real life, because it's okay to do this. Like, say you do take cervical spine and immobilization, it's okay to potentially do this after you check your head, chest, and neck, and you go to the back so that you can get it out of the way. And that's a real life application. Obviously, National Register wants you to follow a specific order, but I'm just saying it. Make sure that you have your tools ready to go the second you roll them, because when you put them back, it's a good time to have your tools behind them so that you don't roll them again later. It's very uncomfortable for the patient, even for your patient, your quote-unquote patient, when you do this for your practical exam, because it's uncomfortable for someone to continue to be laying there on their side. I know this because I've been the dummy where I've been rolled on my side multiple times. It does get uncomfortable. So just be respectful to whoever's volunteering as your patient. Then you get to your reassessment. So you're going to demonstrate how and when to reassess the patient. Say and show how you would reassess the patient and why it is important to continually reassess. Obviously, just like with medical, explain your rationale. That's the big point here. And especially for trauma, it is very important. And you're going to explain vital signs every 5 minutes instead of 15 minutes when compared to a medical emergency, especially for trauma. It's usually going to be a serious enough trauma emergency. That's why you do it every 5 minutes versus 15. Same can be said for medical, obviously, but here they're really honing on the trauma part to make sure that it's every 5 minutes for vital sign checks. And for this one, this is your last chance to find anything that you could have potentially forgotten in your secondary assessment. This is your absolutely final chance, because you can go back through everything. If you did forget something, you can say, oh, I forgot to check this, so we're going to check this real quick. So again, if you forgot to check their back, now is your time to do it. Or if you forgot to do a certain thing on their back, you can roll them a second time. You can. There's no point value saying that, well, you rolled them 5 times. No, do your assessment. Do it thoroughly. If it takes you 5 times to roll them because you kept forgetting something, then do it. But just remember, I share that with you just for a future reference with patients in general, because a patient, especially an elderly person, they don't want to be rolled 5 times. So I'm just helping you be more efficient, and that's why I'm sharing that with you. Then, of course, here's the final question of the assessment, the ultimate brain stopper, as I like to call it, that the proctor will ask you, is there anything else you would like to do? Remember, this is your last chance. I know I said it on the last one, where it's the last chance to find anything that you could have potentially forgotten in your secondary assessment. This is your last chance for anything besides your primary assessment that you can do, such as if you forgot to do your vital signs, you can take your vital signs now. If you forgot to say your patient priority, which I can't remember how I worded it, you can still say your patient priority, especially if they say, well, your ambulance is on the way still. Okay, you can go back and reassess thoroughly. You can do your head to toe again here if you would like to make sure you have all your bases covered. Because if you do your head to toe again here, and you do something that you forgot, and you verbalize it here the second time, you did it then. The proctor will acknowledge that. That's okay. It's when you say, no, I am done, or there's nothing else I'd like to do for this patient, that's when you're done. That's when your timer stops, and that's when you're done overall with that station. So again, that's your final point to make sure that you got everything that you need to get. So in summary, can't remember if I have, there it is. Okay. So in summary, there are a lot of steps for patient assessment. However, there is a lot of overlapping to help with memorization. That's the nice thing, especially with trauma and medical. Just know that some of these are in different orders a little bit for certain things, but generally speaking, a lot of the same things are on both skill sheets, especially your ABCs. They're actually technically the same. They just have a different way of having you explain the ABCs because it's a trauma versus a medical. Trauma, you're going to have to worry about opening an airway and inserting an adjunct and applying oxygen faster versus a medical ABC, such as medical problem, your patient's usually conscious enough where they can open up their own airway on their own and talk and maintain it enough so that you can get to applying oxygen later, not as immediate. So there's just a little bit of difference with each, but overall there is a lot of overlapping, which is nice. Keep in mind of the auto failures on the bottom of the sheets. Just like I said earlier, I didn't memorize them. I just memorized the whole sheets altogether because it's better to memorize the steps that you need to know versus the auto failures, because if you memorize something that you should not know, you're most likely going to remember that long term versus memorizing the steps that you should know. That's the only reason why I say that. If you memorize both the steps you should know and the auto failures, more power to you. I didn't want to memorize that much stuff. So I just wanted to memorize each point of that I should know and do. And do not be afraid to touch your patient when assessing. This is a touchy profession. This is your touchy station as well, that you show your proctor that you know what you're doing. You're touching your patient for assessment so you can show your finding, or that you're physically doing something to look for problems, whether it's medical or trauma. on your patient. You're not shy with these patients. You can't do anything for patients if you don't touch them, basically. The first 5 steps must be completed before any official patient contact and can be completed fast. I say official like that because obviously it's a practical station for National Registry. They want you to have them done before you do your patient contact. If it's real life, obviously it's a little bit different, especially if you have patients that walk up to you, run up to you type thing. That's a whole different story. But just know that, especially for your National Registry skill sheets, your first 5 steps need to be done before any patient contact, and they are usually done relatively fast. Especially the more you practice, you're going to see how fast they can be done. Especially if you watch your fellow firefighter or EMS personnel on your departments, and you can see how fast that they can fly through. It's just, they're very easy steps. That's why I say that. ABCs must be assessed first before any other assessments. Remember, there's a reason why the ABCs are called the primary survey, primary assessment, resuscitation, because they need to be done first before you do anything else. Because without your ABCs, you don't have a patient. Your patient's not going to survive, and that's why they have to be done first. The ABCs maintain life. Your ABCs support life. They are the crucial 3 steps, airway, breathing, circulation, that must be secured and established first before you do anything else for your patients. Secondary assessment for medical is mostly questions, as we discussed earlier. It can be touchy for the patient. You can touch your patient as well for it. Just know that's going to be mostly questions. And for trauma, it is mostly touchy, doing a head-to-toe style assessment. And that's why they have it listed the way they do on the skill sheet, because you're really starting from head to toe. Obviously, formulate your own plan. They don't care as much what order you do things in. Just make sure you get your core done first, like your head, neck, chest, abdomen, and pelvic region done first. Then you can do your extremities or your back next. They don't care necessarily. And you can even check the skill sheets on the bottom. There's no specific order once you get your core areas checked from your head to toe for your trauma assessment done. Just get them done, and you touch everything that you need to touch for assessing the patient. Then always reassess every patient. 15 minutes for a medical call, 5 minutes for a trauma call. That's just a general rule of thumb. Every 5 minutes that you reassess your trauma, 15 for your medical, just because of your patient stabilization. You can do 5 minutes every 5 minutes for your medical call. Obviously, if it's a serious medical call, priority 1, critical call where your patient's deteriorating rapidly and they have a serious medical condition. But just know it's a general rule of thumb of 15 and 5. That's what they're getting at here. Practice with your classmates or department members. I cannot overemphasize that enough. Practice, 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 practice. That is how you're ultimately going to memorize these sheets. Practice is the best way to remember everything you can learn, something completely new that you may like for your assessments. So it's the best way that you can practice getting your routine down and remember everything for these 2 stations, because like I said earlier, the medical and trauma assessments are the most intimidating for all students. I remember when I took them, even for my when I did my paramedic National Registry. It is intimidating because there is so much on them, and you can forget steps fairly easily, and that's okay if you feel that. But just know that overall, now that I've been doing this for so many years, it does help formulate your field assessment when you do get out in the real world. That's why it is the way they have it set up. And it is actually very nice. So actually take it as a compliment from the National Registry that they actually help you formulate your actual patient assessment in the real life. Obviously, you're going to learn shortcuts and cut corners, but that's different. I'm not going to support that yet here because the National Registry does not support that. But just know that it is your foundation to your patient assessments for both medical and trauma. So that is the beauty of it, and that's why I say just practice, 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 practice. And you'll see what I mean the more you start getting out in the field and you start seeing your department members actually assess patients when you're learning how your department functions. So it's pretty neat to watch all that. So here's my reference. Really, like I said, I took everything from the National Registry site, the EMR section of the nationalregistry.org website. The skill sheets for medical and trauma patient assessments are there, and like I said, I just went off of those skill sheets. So like I said, this is my reference. That's the link. Very easy to find. Just type in Google National Registry if you want. You can go on the website, search it that way, or National Registry EMR skill sheets. Boom, it'll take you right to it. Very easy to find. If there's any questions at all, at any point at all for either medical and trauma assessments, please feel free to leave your comments in the questions in the comments section of each video if you have specific ones for that assessment or whatever. Or if there's things that you didn't like on this, please let me know so that I can either explain to you why I said what I did, or maybe I just said something wrong that you caught. Obviously, I am not perfect by any means. I am still in this field practicing as the medical terminology goes. Because, like I said, it is a field. It's unfortunately, it's a continual practice. I am still learning lots of things. I've only been in this for 9 years as a paramedic, so there's still lots of things out there that I'm learning. Like I said, I'm just doing this to help you guys, and there's lots of good medics out there that you can learn from. EMTs, EMRs. I've been doing this for many years, longer than I have been a paramedic for, that even I learn things from. Just because I'm a paramedic does not mean that I know all. No. I learn things from everybody. And I say that proudly because we are a team. From an EMR to a paramedic, we are all a team working together for the patient's greater good. So I say that proudly. I say that happily. And I am more than happy to work with whoever with things I said wrong, agree with, disagree with, and so that we can all ultimately become better clinicians in the field to improve patient outcome. So thank you for watching these videos, and I hope you guys have a good rest of your day, and I hope these have been very informative for you. So keep your eyes open for future videos. If you guys want more of these videos for whatever skill sheets and whatever levels from EMR to paramedic, let me know. I'll make more videos then, possibly. And these are my own PowerPoints that I made myself. So, like I said, just let me know if you like them. I'll do more then. So, take care, guys, and thank you for your time.